Welcome to this video on sepsis and septic shock in the emergency department. This simulation is designed for residents and doctors to improve clinical decision-making. We begin with a 68-year-old female presenting with an acute change in mental status, subjective fever, and a 3-day history of cough. Her vitals indicate tachycardia, tachypnea, and critical hypoxia, requiring immediate intervention. Early detection is vital. While QSOFA is specific for mortality, the NEWS score offers superior sensitivity for early clinical deterioration in the ED, flagging this patient's critical risk. Understanding pathophysiology is key. Sepsis is defined by organ dysfunction from a dysregulated host response. Progression to septic shock involves persistent vasopressor requirements and elevated lactate levels. When considering fluid resuscitation, evidence suggests balanced crystalloids are preferred over normal saline to avoid hyperchloremic metabolic acidosis and potential renal injury. Dynamic perfusion targets are essential. The Andromeda shock trial highlights that targeting a capillary refill time of less than 3 seconds is an effective, non-invasive endpoint. Early initiation of norepinephrine is critical. It restores venous return and perfusion pressure, helping to avoid the complications associated with excessive fluid loading. The golden hour mandate requires 2 sets of blood cultures before starting broad-spectrum antibiotics, ensuring treatment remains targeted based on the suspected source of infection. Source control is an absolute prerequisite for resolution. Whether through bedside procedures, interventional radiology, or surgery, the primary focus of infection must be eradicated. For refractory cases, a multi-receptor strategy is needed. Adding vasopressin as a second-line agent can be catecholamine-sparing, while epinephrine serves as a third-line rescue for myocardial dysfunction. Hydrocortisone may accelerate the reversal of shock in refractory patients. Guidelines suggest its use only after adequate fluid and vasopressor therapy have failed. Intubation in septic shock is high risk due to the potential for hemodynamic collapse. Pre-oxygenation, careful agent selection, and protective ventilation are mandatory. In summary, recognize early, prioritize balanced fluids, start pressors early, monitor perfusion, and ensure definitive source control to improve patient survival.